just a discussion more than anything else on our changes with the Code S that we implemented about 3 years ago system-wide, and it's been a success. Now we are facing the challenges of volume and Cape Coral going live really stretched the resources thin as well for the system. And we're honing down and we're trying to see how we can lean the process, so to speak. So one of the things that you are going to hear about in the upcoming several months is a process of process improvement that is going to be through the Lean Six Sigma methodology. And for those of you who don't know what that is, it's basically taking the door-to-needle times, report cards, following the metrics, creating a flowchart, and the flowchart is not a clinical one, it's a administrative one, where we pinpoint down the metrics that we're looking for. So for instance, the way that we're doing it now with our report cards, there is a lot of flaws in there, because if there is some problem, it's difficult to pinpoint it down and see where the problem is. You know, you want to make sure that you make your metrics as narrow as possible, so we can find out how we can improve the process. We've actually, system-wide, the process has been pretty good, and to a point that right now the delays are very little, and when there is a delay in something, it really shows up, and it's, but sometimes it's difficult to pinpoint exactly what the problem is. When you have a metric of, door arrival to neurology at bedside, that metric will bypass a lot of the steps, and so it's difficult to pinpoint. The real metric for instance, for neurology at bedside would be, MD calling the neurologist to neurology at bedside. That would be the real metric. That's just an example. So when the metric is very broad, then it misses. It's difficult to pinpoint it and see what the issues are. And now that we're being stretched thin, it's important for us to follow the metrics a little bit more closer, because we all want to know if there is a delay, what the delay is due to. So the new process improvement will, I'm anticipating between now, probably between December 1st to the end of the year, we'll collect some data and not make any changes. And then the beginning of the year is when we actually look at the flow chart and look at where we need to make a change, and then talk about a process improvement at whatever level that we're looking at, and then collect the data again. And the data is real-time data, and the data will be on every single one of those metrics. Unfortunately, Epic doesn't allow a lot of the data collection that we want. It's just not built in Epic. It's a horrible program for that. And so it can give us some data, but it's missing a lot of it. So we do rely on those blue sheets, what do you call them?
The tracker forms?
The tracker forms. And when we went back and looked at the tracker forms and see how much data we actually have from tracker forms, almost every single one of them, if it's there, almost every single one of them is missing a whole bunch of things. That's it. So we have to, if we're going to collect the data, we really have to emphasize that. And I don't know how we can do that. I mean, the best way, I guess, would be their directors and nurses.
Well, our campus has done very well with it being complete. I sent you the one report, but
everything.
Our supervisors are taking ownership of that form to be complete.
The last time we talked about it, last time we saw it was missing a whole bunch of things, but that was about a month ago or so. So we'll take a look at that again. But it has to be like from December 1st on. Okay. We have to make sure that it's 100%. Because if it's missing some data, then it's difficult to know. Like, remember, we went over the data before. I don't know if it was with you or with Tricia, but we went over, I think with both of you, there were like 5 cases, and 3 of them were missing this part of the data, and 2 of them were missing the other part of the data, and when you put it together, it's difficult to make any sense out of it. So when the data is not there, it's very difficult to interpret. Because the numbers aren't very large. When you're talking about the N of 5 or the N of 10, you really want to make sure that it's all there. So that's the one issue. I think we have to make sure that, you know, system-wide it's 100% there. The other issue is that, so when we have the flow chart, we'll take a look at that and we'll see what is the sort of process improvement that we need. We sort of semi-did that in the past year, you know, with laboratory and different things that came up, and I think that here we learned experience from Gulf Coast. You know, we had that as an advantage here, but we will see what else will come up, because I think when we looked at the system in general, we have, you know, done a great job and improved and plateaued now, and so now we're going to look back and see what else we can do to get the door-to-needle times a little bit better. Our goal is 60 minutes of door-to-needle times. At the same time now, with Code S, we're also noticing that there are a lot of calls that are coming in, you know, that really are very obviously not Code S. And so it's important to relay to everyone that the Code S number is not a quick way of accessing the neurologist to kind of ask a question. This is actually, you know, stroke alert. Because what happens is, this is our cell phones. I mean, you directly will call the cell phones. So just imagine having this with 4 campuses and taking call. It's an impossibility. You know, we have to make sure that we use it the right way. And for cases that are very obvious, like if the patient is pregnant, you know, I put some of this stuff here. Age below 18, patient is pregnant. There is a bleeding complication in the non-compressible site. Number 4 there is surgery, and I'm thinking of removing that because that depends on the surgery, and you know, that's subjective. So, you know, I think you guys have should be the judge of that. So we'll probably remove number 4 there.
If you're keeping it right now, what do you consider recent? Because I mean,
well, for instance, if it's spinal surgery or intracranial, that it would be 3 months, for instance. And if this is a stroke alert on the floor, for instance, and they just had a bowel resection, so you know, I think everybody probably has a very good sense of that. I'm going to go ahead and remove it, just because you know, I think it's individualized. And then patient known to be taking Pradaxa, Xarelto, or Eliquis. You know, there are, and right now when we have just this protocol, just a TPA protocol, you know, we cannot give TPA to patients who are known to take those things. You know, like I literally walked to a patient's room, you know, with a Code S, and the patient said, "Yeah, I just took my Pradaxa." And it just take a simple, you know, question to ask that. But the issue here is that not that it wasn't asked. You know, the person thought that we just have to call them these things anyway, or I would get, you know, we all would get calls. Well, the patient just woke up with this, and last time known seems 9 p.m., but we're told we have to call you guys on this, and it's more stress on you guys, and it's more stress on us, and more stress on the system to think that you have to do that. But so it may be just a practice of just relaying the message. You don't have to do that.
So if I can interject,
yeah.
so excuse me, what you're saying that is we should screen for the exclusions on our own. And if there's any one exclusion, there's no need to call.
Right, but maybe if there are, you know, some hardcore stuff, so I try to take out the hardcore stuff and put it here, you know, and at the beginning, when the patients are coming in and you don't have a history, you don't know anything, and you want to expedite things, then just call. But when the patient is alert and they can give you a history, and it just takes a couple of questions to go through this, are you taking Pradaxa or Eliquis or Xarelto or Coumadin? And I put the brand names there for a purpose, for a reason, because that's what's known. You know, if you can get that quick history, you know, then it's an easy, quick screen. You know, if they're on Coumadin, they can tell you that their INR is above 1.7. You know, I just took my INR, it was 2.5 yesterday. I mean, that's something that you can. If that's something you can get. If it's not something you can get, then it's not. And as a matter of fact, right now, what I'm noticing is the pharmacists are doing such a good job with this that they, you know, patient is rolling in, they're pulling all the medicines, and they already can tell you if their patients are Pradaxa or Xarelto. I mean, it's amazing. The pharmacists are doing an incredible job with this. So, you know, sometimes, a lot of times that information is readily there.
What about the bleeding? It says no bleeding complication at non-compressible site. Over what period of time? I mean, if they say I had a GI bleed 6 months ago, if I had a GI bleed, you know.
Yeah, there is, you're right, I should specify that. It's, I believe it's 3 weeks for GI or GU bleed.
3
I have
weeks
to
for
go
GI.
back, yeah, I have to go back and look at the criteria, I think that that's what it is. I don't have to specify that.
Okay.
At a non-compressible site.
Yeah, because I'm thinking the GI is a common one that we
Yeah.
see a fair number of people who have had a GI bleed at some point.
Might be the most common.
But
Yeah, I mean, there are patients who, I mean, if the patient's walking in and they're vomiting blood, you know, or there is a clear history of a GI bleed, you know, dark tarry stools and patients been in the hospital. I mean, there are a lot of situations that comes up that you can, you know, take out. Well, it has to be seen more than 4.5 hours, you know, that takes out of everybody. You know, if you're 80 and above, the rules are different, that's 3 hours.
Well, if the window's 4.5 hours to begin with, so if.
The window's 4.5 hours, right?
So, I mean, and we're saying, say our goal, our best goal is try to get it done within an hour.
It really should be, you're talking about 4 hours, right? I mean, right, that's the way it should look, right? But I mean, I left it at 4.5 hours just to give it the benefit of the doubt.
Okay, I'm just saying,
You know,
I'm just
but
trying
you're
to
right,
do
you're right.
the
I mean,
math.
yeah, we thought about that, you know, that might be, because you never know, sometimes the history will change and say, no, it was really this.
Okay.
Yeah. So,
So the other question that I have though is patients that, because again, we're talking about now, this is obviously for TBA, but then you also have the other arm about other potential interventions. So the patients that come in who, you know, with the two nebulous sides, people that you think that are, you know, it doesn't really sound like a stroke, but they're saying that they're subjective numb, and people who clearly had a stroke, but they woke up that way. And so, do you not want to be called for the people who woke up that way that clearly have significant deficit? They're paralyzed on the one side, they got a facial droop, or you know, because you know they're not going to be amenable to any intervention, so we're just going to not call it and do the CAT scan and give them their dysphagia screen and aspirin.
right. So, yeah, so, well, you're really asking a couple of questions. One is, what do we do with the wake-up strokes? And number two is, what about endovascular on wake-up strokes and non-wake-up strokes? And this was actually one of the topics of discussion here. With the wake-up strokes, the same rules, right now, the way it stands, the same rules will apply, you know, for the 4.5 hours. However, there is a lot of literature that is popping up on wake-up strokes, and it turns out that most people who wake up with a stroke just had the stroke right before they woke up. So sometimes, you know, what I personally do is I sometimes will think outside the box and get the CTA and CTP and get fancy and see if there's a mismatch and if there's, and I've actually done that. I've actually had a good result in a couple of patients. That's experimental though, you know.
Right, but that's sort of where I mean, that you know, it's kind of the nebulous thing. I don't want people to turn around the following, us not to fill out the form, not to give a call, and then someone come back the following day saying, you know, you screwed up, you're supposed to call us on these.
That's
so.
why we have the protocols though. I mean, you know, you can't set that as a protocol in the system. You know, if you are going through the protocol and everything is by the protocol, nobody can blame you ever.
Right, but by the protocol, we're not calling.
Right.
Okay.
Exactly.
So we're not gonna call for the
For
awake
the
stroke.
wake-up strokes, right, because there's
Okay.
no evidence for it.
Okay.
You know, I mean, I think I'm the only neurologist that might take a look at that wake-up stroke and say, you know, let's get a CT and a CTP, and that may be the case in vast majority of states. Vast majority of neurologists, you know, won't treat that wake-up stroke with TPA awareness. So because there's just no evidence for it, something happens, it's liability. So wake-up strokes, you know, right now the way that it stands as practice, you know, around the nation, as a standard, you know, beyond the 4.5 hours, we don't treat with TPA.
Okay.
So having said that, that might change if there's better data. You know, the data is questionable right now. When there's better data, then that might change. If it changes nationwide, then we might change practice according to what's changed nationwide. But according to the AHA guidelines, we don't treat those. As far as endarterectomy, there are now very good evidence to show that endarterectomy is no better than TPA. So the practice of what to do with these patients who are not candidates for TPA, whether or not to do thrombolectomy, that's also thinking outside the box. Now, when we don't have it available right now. So it's haphazard, you know, whenever the guy is available, we might be able to do it. So when there is not a 24/7 service, you can't implement it as a protocol. It has to be always there to know that, you know, you can do it. Now, as of March, we're going to get a couple of new people that are going to come in here, and the new biplane will probably be ready to go in June, is my guess.
Could you explain biplane?
Yeah, that's the endovascular suite. That's the radiographic suite that they can actually do the procedure.
Where will that be located?
That will be located in the Comprehensive Stroke Center, which will be Gulf Coast Medical Center.
Which will entail a transfer.
Right.
So we'll have to go over the transfer protocols at that time for the
At
indication
that
of
time,
biplane
right.
therapy.
So at this point, I wouldn't worry about it. When it's available as a 24/7 service and they want to do this, then we'll talk about it and we'll see what changes we need to make. And what the protocol would be for transfer and what we need to, you know, the decision maker for transfers would be the neurologist, so you would have a lot of help. You would have to make decisions on who to transfer. But we will have to work with them because they're not even here. You know, I can't really speak for them, you know. So we would have to work with them and get them involved in these committees and see what they like to do and what protocols they're comfortable with. You know, age above 80 is probably not going to be a candidate for them. They're going to look at the NIH stroke scale. You know, there's criteria that they look at. So we would have to put together that protocol with them when they're available. Outside of that, so we're not even going to think about that right now. We're just going to think about what we're going to do with the system right now until it's available.
Improving symptoms, so pre-hospital versus.
I didn't put that in here because that is, you know, the original criteria said to rapidly improve symptoms, and you know what is rapidly? You know, if they're aphasic and they get arm weakness, and then the arm weakness gets better, but they're still aphasic, do you treat or not treat? I think that's bogus criteria anyway.
So on those, we should, I'd rather on those call.
Okay.
Okay,
Right.
but it's gotta be, that's what I'm saying, these are the things we have to let people know, because
Right.
we get the meetings afterwards when everyone says that we did things wrong. So I
Yeah.
wanna,
But that's why I want to set protocol that is set and written, and that's why I didn't put that in here, because that's subjective. You know, the other thing that's subjective that I didn't put here that would be a hard call would be the glucose. If they're hyperglycemic or hypoglycemic, you can fix that. You know, if they are hypertensive, you can fix that. You know, if they have had a seizure, it doesn't mean they didn't have a stroke. That's subjective call too. You know, so I didn't put that in here because I'm going to leave it to the neurologist to kind of figure out. You know, many times, you know, it's a seizure as opposed to ictal paralysis. But there are times when people have a stroke and a seizure together. So I left that out of here. But these are some of the very obvious hardcore calls that you can actually screen out a lot of patients that may not need to be called and relieve the burden from the system of calling these things. And I think most of these things here are, you know, I think as far as, you know, besides number 4, surgery, you know, I'm going to take that out because it's obvious, and, you know, if somebody has an open wound discussion blood, you're not going to call it, you know. Yes, sir.
What, any role for intra-arterial TPA?
Well, that's part of when endovascular suite starts, that's going to be part of that. So intra-arterial or thrombolectomy, everybody's moving away from the intra-arterial and going to thrombolectomy. But a lot of times, when there are distal branches, so when it's a main branch occlusion, thrombolectomy, when they inject the dye, they don't see anything in the branches, M1 or M2, and it may be a distal M3 branch, or maybe a shower of clots. They might go ahead and inject some intra-arterial in those situations. But again, that goes back to the endovascular talk.
Okay, so you touched on the stroke mimics, someone who quote unquote had a seizure, everybody, whatever, who knows how reliable witnesses are, say the patient had a convulsion, we saw it, does that automatically eliminate it? What do we do with the borderline cases, the stroke mimic cases, the Bell's palsy where the patient swears their face is numb, but you're pretty sure this is a Bell's palsy? Should we or should we not call?
I think that will be your comfort level. Getting numbness and facial paralysis, or feeling that the face is numb is very common. It's not true numbness.
Absolutely,
Very,
I
very
agree with
common.
you, but then what do we do with that mimic case at 12 o'clock at night? Should we call you or should we not?
Bell's palsy, if they clearly have weakness in both the upper and lower part of the face, and there's nothing else going on, they can have a brainstem infarct, potentially affecting cranial nerve number 7, but just having that and nothing else is unusual. If they just have that, it's Bell's palsy.
Those sensories
so if we're
intact, don't call you.
Yeah, I mean, if your
patient
if your
says they have
examination,
no feeling in their face.
right, and the sensory is intact. Just think about it, when you say numbness, the vast majority of times when I hear numbness, it really means weakness,
Correct.
right? And when your exam is just showing this facial weakness on one side and
But
nothing else.
If you tested for numbness and the patient says, I cannot feel that.
Yeah, if you're not sure, just call. If you're not sure,
So in
call.
case we're not sure, call anyway.
Yeah. These are the first responders, right?
Well, and yes, and I want to make that clear, that, we do the very best we can. I think the resources are stretched, but in cases of doubt,
Yeah,
we're more
if you're not-
likely.
Look, I mean, if you have a 40-year-old that comes in with what looks like a big stroke, but they're outside the window, use your judgment. What I don't want to do is to open up the floodgates to all the Bell's palsies. All of a sudden, you really get screwed. The system really gets screwed. But if it's a case that you're uncomfortable with, and you really want the neurologist there, call it. But if you're not, if you're sure, I mean, the exception to the rule is that's the exception to the rule. The rule is that a lot of the calls that we get is, we know this is not a co-stroke, but we're told we have to call you. Well, no. So that's the misconception that we have to, you know what I mean? But if there are cases that you don't get uncomfortable, look, if a 45-year-old, then you're gonna, it's 5 hours, but I'm gonna get this patient out to Tampa or somewhere else, or Naples or Tampa or somewhere else to get a thrombolectomy. Yeah, you have to be involved. I mean, use your judgment there. Does that make sense?
Yeah. On the, we redid the stroke order protocol, remember, all of the committee did that thing. One of the boxes that was added as an option is the CTA, CTP.
Right.
Now, I noticed there's some variability among the neurologists. Some like to, when you call them and say, this is an interesting case, I want to get a CTA, CTP before I get there, or at least start that order.
Right.
Whether one of those boxes is supposed to be checked
Yeah.
and under what conditions?
Yeah. So the variability is there because the trials that looked at that, including the relatively recent MR study, was a negative study. So really there's not a good data to use that as a guidance for anything. And number two, there's no protocol for that until endovascular gets here. So in the absence of protocol and absence of good data, you're going to have the variability. I mean, I don't know how to, what to do with that until that happens, until endovascular comes.
So the decision to check the box, CTA, CTP, we just leave that to the neurologist.
Right.
But we'll just get our finger stick glucose and routine
Yeah, the routine
non-contrast
stuff.
head scan.
Yeah, the routine stuff.
How long does those CTA, CTP take here?
That I don't know.
I don't know about here, but I can tell you, my experience at Gulf Coast has been that it takes very little time to do it, but it takes a long time to prepare it.
The images.
Yeah. Because it's three-dimensional and it takes a while to prepare it. So I usually just go and look at it myself and while they're preparing it, I sort of can give them an idea what it looks like. If there is a main branch included, is CTA, quick CTA will show it to you. That's the quickest thing. But to look at the perfusion studies and to do the reconstruction, you have to put the markers and get the numbers right. That takes a long time.
Tammy, an unusual question. I think we had a couple of cases several months ago where someone came in with one symptom, chief complaint, and then when they finally came back 30, 40, 50 minutes later, whatever it is, it turned out they actually did have a neurologic deficit. How do we, well, obviously at that time we would start the,
You mean
what
they
is the time
present
zero
with-
at that point?
They present with one symptom that's kind of resolving, they go to CAT scan, they come back and there's.
No, they present with one symptom, headache, feeling weak,
Uh-huh.
not dizzy, then you go back to your exam and said, well, how long have you been dropping your cup of coffee?
sure.
Oh, that just started this morning. Well, I
Right.
thought you were here for a headache. Well, I am, but I can't use my right hand.
Mhm.
And
Yeah,
so they've
their
been out there for
stories
45 minutes,
Mhm.
and they're really here for a headache, and it turns out their right hand is weak.
We would still proceed, I mean, unfortunately, because of the fact we go on arrival time, you're right, our times would be out, but if they're within the window, call it. It's not your fault, you were not given that information. Headache, dizziness, those symptoms, they are actually in triage, bringing those patients right back to the room and acting as if it's a stroke alert, if they're within that window. So, if you've not been alerted to that patient and it being within a window and the symptoms, that's not your fault. So, I
Right.
mean, and we, Rose and I, we do go over our tracker forms every week and narrow it down. And we would never put that on the ED physician because you were never, you didn't know. And that's just for internal anyway, you know,
Right.
it's just an evaluation that we're
Sure.
doing on our own process.
And so again, you may see what that may happen. Someone comes, the history's poor, the history's vague, you call the neurologist, and says, why did you call me an hour and a half ago? It's, well,
Yeah.
we just have new information now. We now have the
Yes.
historians here, the family or the friends, the neighbors drove, they're giving
Yeah.
us the real story. So,
And there are times where, the story isn't there until the family gets there. We've tried to work with the EMTs to give us the one piece of information that we need, which
Right.
is the phone number of the family, and that still gets missed.
Yeah.
But, in case you don't have the history, I would call. I wouldn't wait for an hour and a half to call in case you don't have the history.
you would call.
And there are times where I don't have the history and,
Yes.
and I make my visit and I still give the TPA. Very, very few times, but I've done that.
Is that true for most of the neurologists?
It's, you know what, again, it's not a protocol driven thing. You have to have the history, you have to have the
Sure.
exclusions.
Okay.
Do you guys want to call on people who symptoms are mild, even though they're the windows? If somebody's got a stroke score of 1 or 2 that we're not going to TPA,
Yeah.
but their symptoms started an hour ago, do you still want that call?
So what's mild? If it's aphasia, that may look like it's mild, but it can progress. So aphasia is one that may have a low NIH stroke scale, Now, if you have an 8 and 9-year-old with a little bit of a facial droop, a daughter goes to nursing home and says, oh, Ethel has a facial droop, and, let's get her back to that's a different story. But so I would use your judgment with that. But yeah, most of the times, mild can progress very quickly.
What about confusion? They're global amnesia, confusion.
As long as they're not aphasic, if they're confused, it's one thing.
They progress, sometimes the people progress with confusion. So you keep watching, waiting, whether they get clearing up or if they're getting worse. The next thing is aphasia of the arm, and they say, oh, my fingertips are numb. And I just can't think what I'm supposed to say, and I don't know where I am.
Okay.
So which way do you proceed to this? Call or not call?
So if they're confused, but not aphasic,
Yeah, which
so,
part of his expression.
right, but if they're aphasic, it's usually if you just ask them, if you do the language, so the naming and repetition, and naming is the most sensitive. If they can't name, if somebody who is 8 and 9 years old and has a urinary tract infection, has encephalopathy, they will be able to name. They may not know where they are, they don't know what their name is, but they're going to name an object for them. So that's a quick and dirty way to test for language is naming. If they can't name, and they're aphasic, they're paraphrasic errors, so they may look like they're confused, but it's really aphasia, then yes, call. But if it's confusion without the aphasia, if it's simple language exam, the NIH stroke scale, you could use those pictures there. And if you don't have that on there, just what is this thing, what is this part of this thing, that sort of thing. You can't name, then there's a chance that it's amazing. So naming is a really good tool.
Do we have those pictures, Mike?
They,
Oh,
they're in
Jonathan's got them.
They're in the stroke folders.
They're
Stroke
stroke
folders,
Okay.
yes.
So if anything, we should be pulling out those stroke folders more often than not. If there's any doubt, pull out the folder and use it as
That's what they're
as a
there
quick
for.
test.
Yeah.
That's what they're there for.
Well, in cases where we're not really sure, the borderline cases, the iffy cases, so to speak. We're not sure, should we call it, should we not call it? So we should probably do a little more investigation versus just hitting the red button and calling the stroke. Pull out the sheet and start trying to get a better
Well, the
definition.
NIH stroke scale, should be done, and your assessment, part of it should be the language function. And if you're gonna limit the language function to the minimal thing would be the naming, so.
Well, as you know, we don't have a whole lot of time to do it.
Right.
Usually our stroke assessment's like 3 minutes.
Right.
How
But
can we do a complete neurologic
probably-
examination in 3
Probably,
minutes?
I would play the devil's advocate and say probably within a minute and a half you can do all that.
Okay.
You can do a language, you can do the naming, the visual fields,
Mm-hmm.
because that's important, you can miss that. The naming, the visual fields, and the, and motor function. And motor functions, drift, deltoid triceps or extensors
Mm-hmm.
are much higher yield than finger flexors. Finger flexors are always going to be normal. And so, so that probably takes about a minute and a half to do.
Okay.
But naming is important, and visual fields are important, because the visual field is not going to be obvious.
You mean visual field of confrontation?
Okay.
Okay.
Not going to be obvious.
All right. Mike, you were asking the question, I just read a recent article saying that, even if it's a stroke, a score of 3, this guy's a golfer, he's dragging his leg. If you don't TPA this guy, he'll be dragging his leg forever. If you do TPA him, he can now carry on as useful, functional. You make him that little bit better, you bring him from a 3 to a 0. And is that really worth it? And the editorial said, it might be. It might not be important to some people, but the whole idea here is to return people to their functional self, to be able to do and be as they were before this event. So there were a lot of comments saying anybody with a stroke scale less than 4, they don't deserve TPA. And one of the other comments was, don't you want to be your maximal, whatever you were before you had this event? So we shouldn't eliminate people with low stroke scales. We should always
That's
call,
right, yeah.
right?
Yeah.
I don't know if you agree with that, but.
I do agree with that, and because a lot of times those are either aphasic or they have a little bit of weakness, which in a very short period of time in the ED can progress to something big. So now if they say, yeah, I'm tingly here in these 3 fingers, I woke up with this and it's been going on for the past week, and if you really delve into the history, it looks like it's carpal tunnel, it's different. Sensory symptoms is questionable.
Yeah.
Weakness, any kind, and aphasia are hardcore.
What are you finding with the headaches on presentation? How often are you finding those turn out to truly be ischemic in origin?
Probably 10 to 30% or something like that. If there's true pain and they have a lot of neck pain, you worry about a dissection. If they have really a lot of headache and then these things develop afterwards, maybe just be a migraine equivalent or a migraine.
Yeah, the migraine equivalent, that's a very tough call.
You call Larry Hobbs for a second, he's been calling me. He gets pissy.
All right.
He's a good guy.
You guys have any other questions?
Can I make a comment?
Sure, Tammy.
If the patient does come in within the window and has an exclusion, I do need documentation in your dictation that the patient was excluded because of,
The
whatever
following
it is.
reason.
And only
Yeah.
because Getting with the Guidelines, American Heart Association recognizes the time of arrival, it also asks time of onset, and then it is expecting them to answer TPA questions. Or one of the choices is there documentation to support an exclusion? Without it being a code stroke, I often don't have any neurology dictation till the following day or later, and I need it for that initial time period. So you guys do it, it's just recently I've noticed that some of them aren't there, and I'm really digging to try find something to support that when I'm answering, the questions. So just please try to remember that, but you guys are doing fantastic. I mean, you really are. You had 27 codes in October. 21 of them were brought in by EMS. 18 of those 21 were actually code strokes, and 5 of them got TPA, and your door to needle time is 55. So that's quite impressive for the very first month for us. The big thing is that we need to show that then for the next months to really show that we've got it together, you know.
Well, as you know, we're coming up on quote-unquote the season, which, you know, the huge burden, which is, it can be problematic because not only for the physician, but just the overall volume number versus the staff ratio versus the throughput of patients, and the cracks start to widen up and people may start falling through it. I'm not gonna make that as an excuse, but
So I have a comment. So we had a case that
Yes.
I had a stroke and I verbally ordered a CT scan. The patient went CT scan, the tech wouldn't do it because I didn't put it in Epic.
Yeah.
Unacceptable.
Well,
Shouldn't
it
happen.
is, and the director dealt with that.
Yeah, I mean, it should be understood. If there's a code stroke, you put the scanner, the CT it's ordered, because I've called it. I mean, if I'm calling code stroke, I'm ordering a CT
Yeah, I've
scan.
run into that too.
So it shouldn't be, I need to, like, you order Epic,
Yeah.
it's ordered.
Yep. Big thing is though, for that,
Yeah.
their only loop, the hole is that who you spoke to wasn't qualified to take an order, but they didn't tell you that, so
Okay.
it won't happen again because Linda spoke to all of them
Okay.
about it. One thing though I can say from a nurse in ER is utilize your secretary and your nurse there because they can.
Well, and I understand that, but I mean,
Yeah.
the fact that someone hasn't actually put the button in the computer shouldn't delay what we're doing. I mean,
You're
it's
absolutely
ordered.
right, and that will never happen again.
I'm
If it
just
does,
wondering,
please let me know, because it's the only way we can change things.
it seems to be when I've been notified of code stroke, it's usually the nurse supervisor who lets me know. Which in that case, I think we should at least minimally peripherally involve the supervising nurse. So should there be a glitch, should that nurse need an extra tech to get something done, you know, we can do that.
Hopefully you've noticed it, because when I come down for the code strokes, the supervisor is taking ownership and being that timekeeper and being
And
right there.
that sheet, the time sheet, who was filling that out?
The secretary is, but the ownership again is the
Yes.
supervisor to make sure it's real time.
Yes, of late, we have been absent a secretary in one zone.
Then it will be the supervisor.
I think that needs to be known, that needs to be made known.
Okay, I'll reinforce
That,
that.
because the what I call the stand-in secretary is
Mhm.
usually a tech.
Yes, they don't know, you're right.
That needs to be, you know, if we want to collect this data, make it reason, like you said, Dr. Mowzoon said, in N number 5, we need every one of these sheets filled in correctly and accurately. So we need to, you know, bring them up to speed on that. Nima, what else can we do what else can the Cape Coral emergency physician do? What do you want us to do?
Well, one last bit of talk is that, you know, as you noted in the last case, you know, we are, as we improve the process more and more, our, you know, bedside presence is gonna be an issue for the neurologist. And one of the things that, and so that might come up as one of the things that's gonna delay the process, because we have to drive to this place. And so, one of the things should be, you know, communicate to you guys on the phone and have you guys do this, and I don't think that most people will feel comfortable with that. But I think a better option would be a telemedicine. That's one of the things that, you know, if we are going to, because we don't have neurologists that live in the hospital, you know, to really get here within minutes, we have to have that for the system. So that's one of the things that's coming up to improve our presence at bedside. And it's for telestroke, it works really well, you know. A lot of, so what we would implement the educational process that the ancillary staff would need here. You know, the ED doc isn't really gonna be tied up with that, it will be us dealing with the ancillary staff.
Okay.
So, and we will work with them to implement the exam and the anti-stroke scale and all that through the telemedicine. So we can essentially be at bedside with that protocol within, you know, a couple of minutes, as opposed to 30, 40 minutes or whatever it takes to drive up here. So that's something that we're seriously looking at that. And we're having some discussions right now with the administration to see when and if we can implement that for the system.
But currently as it stands, do you see anything else that you would like us to do as emergency physicians?
Okay, I think we talked about everything.
Okay.
I think we talked about everything.
Two quick comments, questions.
Yes, sir.
Any thought of, and this would be more for ED, so they have point of care bedside INR? That comes back in seconds?
We
for
do?
the- No, they have it.
Oh, yes.
It's
Oh, no, it's
here.
available,
So it's
absolutely.
available. So why isn't that something that we've looked into, so that we're not waiting for coags on someone? The other question, and it would be more, I
It's
guess,
available here.
is it point of care INR? Yeah, I mean, I don't know.
Is it
what-
available?
I don't know, I've used it
No.
other places I worked at.
No,
I'm not.
I don't believe it is.
But they
No,
have
it's
just
not.
asked that,
Dr.
so
Schultz?
I'll find out,
I mean, 'cause
okay?
the place
Do you
I
know
worked
this?
is for
I
stroke and
can
coag.
answer that.
Is it over at
Point of
Go?
care and radiology has it, but it is not allowed to be utilized by the emergency room
Oh.
staff.
Oh, okay.
It's politically, there's a lot of red tape around that, because I actually had looked into this several months ago, a long time ago, I looked into this. And it turns out there's issues with reimbursement, and I think there were like 3 different issues that came up that just tied it up. I mean, I looked at this, I had several meetings with the key individuals to do this for the system,
Yeah.
because it just makes sense, it's available.
Yeah, I've used the other place I worked at, we do it
Yeah.
for trauma and for stroke. But,
So.
In the ED.
Yeah.
Mhm.
yeah.
I think what it comes down to is, I think it's political red tape,
You're right, it's
For,
ability.
for a test, what's the cost, $10?
for whatever it costs, I don't know,
Okay,
you know,
I'm-
I was just.
silly.
I'll just find out where it
You can
is.
inquire, yeah, you can, I mean,
Okay.
it might change, I don't know,
Sure.
I mean, this was a while back that I inquired into it,
Yeah,
so you can ask again and
I'll
see.
just find out where that,
Yeah.
I mean, if you
Stop.
can implement it here, I can say, oh, look, Kip Crow's doing it, why aren't we doing it?
The other question, is any thought of letting EMS activate a code stroke in the field? And I only asked this, other stroke centers I've worked at, we did that, it worked fairly well, it cut your times. Obviously, the ED physician is still gonna see that patient on arrival and can easily cancel it, but it kinda gets the process going. The neurologist
Yeah.
is notified,
You
the
know-
CT scanner's cleared.
I think that that's gonna be the future, I mean, I think we have to look at that very
Particularly
carefully.
since she said 21 to 27 last month came by EMS, is it right?
21, out of 27, that's
27,
right.
most of our strokes are coming by squad.
Right, when we looked at the numbers, there's a very high false positives from the EMS, there's about like 30-40% of
Right.
them are false positives. So it saturates the system very quickly to call all of them stroke alert. However, there is a way to do that, and one way would be to actually through telemedicine. There's actually centers that actually take a very small unit
On
on
the
the
squad.
ambulance, yeah.
Interesting.
And you can actually do telemedicine through that, and, you know, I think if you have the right protocol, it can actually be very, very helpful.
Yeah.
I think that, you know, that's gonna evolve with time and, you know, probably not something that we're able to do right now. I mean, I'm having a hard time, you know, talking about telemedicine, with the administration. The administration is very, they're approving of it,
Yeah.
but there's a lot of questions, it's gotta go through committee after committee and, you know, so it's a lot of, and we have to make sure that everybody's on board with it. You know, you're one of the ED groups, there's more than
Right.
one ED group, you know, there's a lot of neurologists, so there's a lot of people that are gonna be involved in that, and we have to make sure that everybody's on board with that, you know, before we implement it. So I think to implement telemedicine, I think is a very good step for us. And then to implement as an additional step, telemedicine for the field, I think will be the way of the future for us, but I think we're kind of far from that right now.
All right.
I'd like to see that happen though.
Well, even in, I just watched something nationally, a lot of the triage nurses are calling it code stroke. Yeah, so, I mean, you can see how things will evolve maybe one day, but.
I mean, we have to adapt what's practical here, but it won't happen. There's actually a big program in France, and they do telemedicine for the people that get sick on the field in the mountains. So, and there's actually these tiny units that they have, so they actually have physician care for those individuals. Yeah, so this.
Kind of like an AED, but a stroke.
Yeah, I mean, this would be for stroke, right?
Right.
So, interesting stuff. Thank you very much.
Thanks, Nima,
Thank you, Dr.
appreciate it.
That's
Thank you,
fine.
Susan.
You're, also, just to tell you, the ED doctors, your average, it's door to doctor, your average, and again, because it actually was 18 out of the 21 were called code strokes, but your average is allowed 10 minutes, your average is 1 minute. Because of the fact EMS, pre-arrival notification, you guys are right there. so. You guys are.
Thank you, Tammy, we appreciate that tidbit of
Well, I'm your biggest cheerleader, so if you need anything, if something doesn't go right, please let me know.
Sign paper?
Um,
Tammy, I've got your number, don't you have, your office is here?
my office is here, yeah.